Today I'm going to talk about placenta. So everybody's hearing me? Can you hear me?
Yes, ma'am.
Yes, ma'am.
So basically human placenta it is a discoid, hemichorial, deciduous and labyrinthine in nature. That means it is just like a coin, round in shape, and it is filled with blood. It is basically made from decidua and it is set after the delivery of the baby. And the placenta it is attached to the uterine wall and establishes connection between the mother and the baby through the umbilical cord. It is derived from two components. It has got fetal component as well as the maternal component. The fetal component is basically from the chorion frondosum and the maternal component is from the decidua bacillis. So you all know by embryology that interstitial implantation of the embryo it is completed by 11th day, and by ninth day there is formation of the blastocyst. Here the picture shows the blastocyst on the ninth day. Okay, the blastocyst is surrounded on all sides by the lacunar spaces around the cord of syncytial cells, and these are called trabeculae. Okay, that white part which is seen against the green background that is called lacunae. Okay, so on 13th day, by 13th day, the stem villi it develops from the trabeculae. So whatever is formed by 11th day, from 13th day onwards, stem villi starts to form. And the stem villi they connect the chorionic plate with the basal plate. And the villi it gradually branches off into primary, secondary, and tertiary villi successfully. So main from stem villi, the primary, secondary, and tertiary villi they develop. On 21st day, the arteriocapillary venous system in mesenchymal core of each vellus is completed. So by 21st day, in each villi, there is formation of arteriocapillary venous system. At third to fourth week, the lacunar space it becomes more confluent and form multilocular receptacle lined by syncytium and is now filled with maternal blood. And this space becomes future intervillous space. Okay. So now something about the endometrium of gravid uterus or pregnant uterus. It has got four parts: the decidua bacillis, decidua capsularis, decidua parietalis, and decidua reflexa. So until the beginning of the eighth week, the entire chorionic sac is covered with the villi, and after that, as the sac grows, only the part that is associated with decidua bacillis retains its villi. Rest of the part, the villi is degenerated. Okay, and villi of decidua capsularis, rest of the part, it is compressed by the developing sac. So there are two types of chorion thus gets formed: chorion frondosum and chorion leaf. Corium chondrosum is villous chorion where the villi is still present, and the chorion leaf it is smooth chorion. The villous chorion it enlarges in number and it branches off and it forms the fetal part of the placenta. And the decidual bacillus it will form from the maternal part of the placenta. So by the end of the fourth month, the decidual bacillus is almost entirely replaced by the fetal part of the placenta. Okay. So growth of the placenta up to 16 week, the placenta grows both in the thickness and its circumference. So by 4 months of pregnancy, the placenta it starts to grow and then it becomes thick as well as circumferentially it starts to grow. And after that, there is a little increase in thickness, but the circumferential growth is there till term. So the picture it shows the fetal part. It is covered by smooth glistening amnion with the umbilical cord, which is usually attached at or near the center. At term, 4/5 of the placenta is of fetal origin. So maternal part, as you can see in the picture, it is rough and spongy, and presence of maternal blood it gives it a dull red color, and it is mapped out into 15 to 20 somewhat convex polygonal areas, which are also known as lobes. The area lined by that arrows, white arrows, it is the lobes or cotyledons, which are limited by the fissures. and only the decidua bacillus and the blood in the intervillous space are of maternal origin, and rest of these are from the fetus. So as I have told you already, the placenta, it is consist of two plates, the chorionic plate, which lines internally and is lined by the amniotic membrane, and the umbilical cord, it is attached to this plate. The basal plate lies to the maternal aspect, and in between these two plates, there lies the intervillous space. And this intervillous space, it contains the stem villi, the primary, secondary, and the tertiary villi, and this space is, it is filled with the maternal blood. So this is the cross section of the placenta where it is showing the chorionic plate, the basal plate, the maternal side, and the fetal side. The basal plate is the maternal side, and the chorionic plate is the fetal side. From within outwards, the placenta, it consists of primitive mesenchymal tissue containing the branches of the umbilical vessels, a layer of cytotrophoblast, syncytotrophoblast, and the stem villi, which arise from the plate, and it forms the inner boundary of the choriodecidual space. The basal plate, it consists of the structure from outwards, outside to inwards. So basically, in the outmost part, there is presence of the compact and spongy layer of the decidua bacillus, and just inside that, there is presence of the Nitabush layer, which is a layer of fibrinodegeneration of the outer syncytotrophoblast at the junction of the cytotrophoblastic cells and the decidua. And during separation of the placenta, it starts from this layer, the Nitabush layer, and it is completely developed at term. So before term, the Nitabush layer is not usually not much developed. So usually in there is high chance of having retained placenta when there is abortion in second trimester abortion and when there is preterm deliveries. And the next one is cytotrophoblastic cell and syncytotrophoblastic cells, and these are perforated by spiral branch of the uterine vessels through which the maternal blood flows into the intervillous space. So the placenta, it is bounded on the inner side by the chorionic plate and the outer side by the basal plate, and limited on the periphery by the fusion of these two plates, and lined internally on the all sides by cytoplasm, and it is filled with the slow flowing maternal blood. And there is numerous branching villi which arise from the stem villi, and it projects into this intervillous space and constitute the chief content of the intervillous space. So the picture, it shows a stem villi along with primary, secondary, and the tertiary villi. Okay. So functional subunit of the placenta is derived from the tertiary stem villi, and the villi surface for exchange is approximately 10 to 14 square meters, and the feeder capillary system within the villi is almost 50 kilometers long. The blood vessels within the branching villi, they do not anastomose with the neighboring one. So it is a solitary unit. Each functional subunit is a solitary unit in the placenta. So in early placenta, each terminal villus has got the following structure: outer cytotrophoblast, then basement membrane, then central stroma. It contains fetal capillaries, primitive mesenchymal cells, connective tissue, and few phagocytic cells. So at term, the diameter of a normal placenta is around 15 to 20 centimeter with thickness of 2 to 2.5 centimeter, and its weighs approximately 500 grams. So placenta and fetal size will roughly correlate in linear fashion, and fetal growth depends on the placenta weight, which is less with small for gestational age infants. Approximately, it is around one third of the weight of the baby. The placenta weighs around one third of the weight of the baby. So placenta separates after birth of the baby through the line of separation through deciduous spongiosum, basically the Nitabush layer, as I've already said. So placenta, it has got two systems of circulation: uteroplacental circulation and the fetoplacental circulation. And a mature placenta has a blood volume of around 500 ml of blood, and 350 ml being occupied in the villi system, and 150 ml lies in the intravillous space. And the blood of the intravillous space is replenished about 3 to 4 times per minute. The poorly oxygenated blood, it leaves the fetus and passes through the umbilical arteries to the placenta. At the site of attachment of the cord to the placenta, these arteries divide into number of readily disposed chorionic arteries, and they branch freely in the chorionic vein to enter the chorionic villi. And blood vessels from extensive arteriocapillary venous system within the chorionic villi brings the fetal blood extremely close to the maternal blood. So this system, it provides a very large area for exchange of metabolic and the gaseous products between the maternal and fetal bloodstream. The oxygenated fetal blood in fetal capillaries is passes into three wall veins, and then the deoxygenated blood, it goes out of the fetus through the placenta, through the umbilical artery into the maternal side. So the uteroplacental vessels, the development occurs in two wave of stages. First wave occur before 12 weeks post fertilization, that is before 3 months of gestation, and it consists of invasion and modification of spiral arteries up to the border between the decidua and myometrium. So up to myometrium, the spiral arteries, they are modified by the invasion of the trophoblastic cells. And second wave of invasion, it occurs around 12 to 16 weeks of period of gestation. It completes by 16 weeks, and by 16 weeks, the trophoblastic cells, they invade the intramyometrial segment of spiral arteries as well. So by remodeling, because of this remodeling in these two phases, the narrow lumen muscular spiral arteries, they expand and the vessels. So more of the maternal blood, it flows into the fetus. So when the second wave of invasion doesn't occur at around 12 to 16 weeks of gestation, if the second wave of invasion is not there, then it may lead to various kind of disease process like preeclampsia, and the baby may get growth, may have small for gestational age or IUGR. So by 16 weeks, if there is no second wave of invasion, then it may lead to preeclampsia, hypertension in pregnancy, and IUGR. Okay? So placenta, it is basically a partition between the fetal and the maternal circulation. It is a barrier between the maternal and fetal circulation, but it's not a perfect barrier. The thickness is around 0.025 millimeter, and is basically formed by endothelial lining of the fetal vessels, connective tissue of the villi, basement membrane, cytotrophoblast, and syncytotrophoblast. So at dawn, it has got sparse cytotrophoblasts and distended fetal capillaries almost fill the villus. Attenuation of the syncytial is thin alpha zones, and there is presence of thick beta zones. And these alpha zones are basically for the gases exchange, and beta zones, they have got the estrogen receptors, extensive estrogen receptors, basically for the hormone synthesis. synthesis. Increased thickness of villus membrane, they are found in IUCR and cigarette smokers. Basement membranes also becomes thicker in those patients, and so the blood flow is decreased, and thereby the baby becomes IUCR. So this is the important part for all of you, the function of placenta. So placenta is basically for the transfer of the various nutrients and gases, for the metabolism, for hormone production, for the production of blood cells, and it has also got immunological function. So respiratory function, where the gases exchange takes place through the placenta, carbon dioxide and the oxygen gets exchanged in the placenta by passive diffusion along the pressure gradient. Sorry, oxygen supply to the fetus occurs at the rate of 8 milliliter per kg per minute, and is achieved by the cord blood flow of 165 to 330 ml per minute. Next one is excretory function. The waste products from the fetus like urea, uric acid, and creatinine, they are excreted in the maternal blood by simple diffusion. Another one is nutrition. Glucose, it gets diffused by facilitated diffusion. Lipids, triglyceride, and amino acid, they are directly transported from the mother to fetus by passive transfusion. Amino acid transfusion transport, they occurs by active transport. Another one is balance of water and electrolytes. The ions like sodium, potassium, chloride, they pass through the placenta by simple diffusion, whereas the calcium, phosphorus, and iron, they are actively transported through the placenta. The water-soluble vitamins, they need active transport through the placenta, whereas fat-soluble vitamins like A, D, E, K, they have slow transfer. Hormones, there are various kinds of hormones which is produced by the placenta. It produces insulin, steroids, thyroid hormones. Other hormones which are produced by the placenta are human chorionic gonadotropin. It rises early in the first and second trimester, and it is low levels after 16 weeks of gestation, and it is responsible for the development of fetal and adrenal cortex. And we see a beta human chorionic gonadotropin for the diagnosis of pregnancy. Human chorionic somatotropin, they help in embryonic development by increasing the fetal cell glucose absorption and stimulates lipid and carbohydrate metabolism. Other protein hormones are human placental lactose, which rises progressively from 12 weeks up to term, and it is basically useful for preparation of lactation and contributes to the diabetogenic effects of pregnancy. ACTH, TSH, melanocyte stimulating hormone, oxytocin, vasopressin, these are all produced by the placenta. Another important hormone which are produced by the placenta are progesterone and estrogen. Progesterone, it basically maintains the pregnancy, it maintains uterine quiescence, and also helps in increase in the mammary growth. And estrogen, it helps in growth of the uterus and vascular supply to the decidua, myometrium, and it helps in metabolism and placental enzyme system. Placenta also there is also it takes up iron, vitamin B12, and folic acid as well. So because of that, there is tendency of anemia in pregnancy. The fetal erythropoietin, which helps in taking up the iron by the fetus, it crosses the placenta to the mother, and so there is presence of increased maternal reticulocyte count in presence of fetal anemia. So having said that, there are various kinds of abnormal shape and implantation of the placenta. The placenta may be placenta bilobata or bipartita, that is placenta duplex or triplex, or there may be succinurated lobes, membranous placenta, ring-shaped placenta, and fenestrated placenta. These are abnormal shape and implantation of the placenta. The picture here shows the bilobe placenta, placenta substituta. These are placenta membranosa, and this is ring-shaped placenta and fenestrated placenta. Other abnormal implantation of placenta are placenta accreta, increta, and percreta, which these abnormal implantation of the placenta will be discussed in detail in antepartum hemorrhage. Then other one is extracorporeal placenta, circumvallate placenta, and circummarginate placenta. There are tumors of placenta as well, gastroenteroplastic disease, chorioangioma. The picture shows the chorioangioma of the placenta, tumors metastatic to placenta, and embolic fetal brain tissue in the placenta. So that's about the placenta. Now, amnion. The term amnion is a tough, tenacious, and pliable membrane. It is the innermost avascular fetal membrane. It is contiguous with the amniotic fluid. It provides almost all tensile strength, and it lacks smooth muscles, nerves, lymphatics, and blood vessels. So the Bone in 1962 described five separate layers of amnion. The innermost single layer of cuboidal epithelium is derived from the embryonic ectoderm. The basement membrane is a cellular compact layer which is primarily composed of interstitial collagen. Another one is fibroblast-like mesenchymal cells, which is derived from embryonic disc mesoderm, a cellular zona spongiaceae contiguous with the second fetal membrane and the chorionic leaf. It is first identifiable about 7th or 8th day of embryo development. Initially, there is a small minute vesicle which develops into a small sac that covers the dorsal surface of the embryo. And as the embryo enlarges, it gradually engulfs the growing embryo, which prolapses into the cavity. So, embryo is inside the amniotic cavity, surrounded by the amniotic fluid. The reflected amnion is fused to the chorion leaf. And the placental amnion, it covers the placental surface and thereby is in contact with the chorionic vessels. Umbilical amnion covers the umbilical cord. There are various abnormalities of amnion like amnionic cyst, nodosum, amnionic band, and oligohydramnios amnionic band. It is caused when destruction of amnion leads to formation of bands or strings, and it may entrap the fetus and impair its growth and development. And sometimes the band may be formed around the um, limbs of the baby, and it may lead to intrauterine amputation as well. So next one is cord. It's developed in the yolk sac and the umbilical vesicle, which are prominent in early pregnancy. Normally, umbilical cord it consists of two arteries and one vein, and the right umbilical vein it disappears early during fetal development, leaving only left a vein. There is a transection histopathology showing the two arteries, one vein, two arteries are there is a thick muscular lined arteries are these are two umbilical arteries, and the lower one is umbilical vein, and this is the vitaline duct, and it is covered with the Wharton jelly. It basically protects the cord from any kind of stress. So umbilical cord, it is also known as funis. It extends from the fetal umbilicus to fetal surface of the placenta or the chorionic plate. And exteriorly, it is dull white, moist, covered with amnion, to which there is presence of three umbilical vessels, which may be seen. And its diameter is around 0.8 to 2 centimeter. Average length is 55 centimeter with a range of 30 to 100 centimeters. And if the length of the cord is less than 30 centimeter, it is considered as abnormally short. And also known as false nut, which are essentially the varices. The extracellular matrix, as I said, that is also known as Wharton's jelly. It basically protects the vessels. And there are two arteries which are smaller in diameter than the vein. So intra-abdominal portion of the duct of umbilical vesicle extends from the umbilicus to the intestine, which usually atrophies and disappears by term. But if there is presence, if it is patent, then it is also known as Maker's diverticulum. And most commonly, it is the most common vascular anomaly. The most common vascular anomaly present is the absence of one umbilical artery, which may be associated with various kinds of fetal anomalies. The umbilical cord it is usually inserted at or near center of fetal surface of the placenta as shown in the figure, and there are various kinds of abnormalities of cord insertion. Number one is Fruquet insertion. The umbilical vessels they separate before inserting into the placenta, and it is known as Fruquet insertion. So the picture it shows the Fruquet insertion. Marginal insertion or battle roll placenta. The cord is inserted at the placental margin. It is found approximately 7% at term, and the cord may be pulled off during delivery of the placenta, and there may be um, the cord may separate from the placenta, and placenta may gets retained inside the uterus after delivery in this kind of marginal insertion of the umbilical cord. Another one is filamentous insertion. Umbilical vessels, they get inserted into the amniotic membrane rather than in the placenta. So that is known as filamentous insertion. That's all. Do you understand?